tanong dito, no? So I think I can proceed now to our last but not the least topic for this evening. So for our last topic, our speaker is a part-time professor at UERM College of Medicine. She is a communication officer of Group of Training Officers of Psychiatry Residency of the Philippine Psychiatric Association. She is a member of the Specialty Board of Philippine Society of Sleep Medicine, a psychiatry resident training officer at the University of the East, Ramon Magsaysay Memorial Medical Center, the head of sleep laboratory also at the UERMMC, and the head of the Comprehensive Sleep Disorder Center at the St. Luke's Medical Center, Bonifacio Global City. Let's all welcome our speaker for tonight, the psychiatrist, sleep specialist, Dr. April PM Fatima Hernandez. Good evening, Dr. PM.
Good. Thank you, Doctora, for that introduction. I am excited to present a very timely lecture. We will talk about sleep at 7:30. So I hope everyone is still awake and ready to listen. So I am sharing my slide. All right. So the title of our lecture today is Exploring the Roles of Lemborexant in Insomnia, a Case-Based Discussion. And to disclose, I am a speaker for Davigo. So our learning outcome are the following. I hope that everyone will be able to diagnose a patient with insomnia after this lecture and provide the basic intervention for patients with insomnia, both psychologic management and pharmacologic treatment. So this is the case of patient CA. She is a 27-year-old IT specialist. She works from home with a rotating shift. She has a sick back with her partner during this time. She also has thoughts of self-harm. She noted to be experiencing, so she would end her shift during this time at 11 p.m. But she would find herself going to bed at around 4 a.m. And when she's in bed, she would spend around an hour before she can initiate her sleep. And she would really feel bad because she would be awake around 8 a.m. during this time. 3 days prior to consult, our patient CA had uncontrollable suicidal thoughts and started cutting her wrist, very shallow cuts on her wrist. This was witnessed by her mother, which prompted consultation at the emergency room. She was then referred to a psychiatrist, hence the consultation. So during this time, the patient did not consent to be admitted in the hospital. For past medical history, she would have on and off migraines, and she was diagnosed with bronchial asthma but was not in exacerbation during that consultation. So I did my MSE on this patient, and I saw a fairly camp woman wearing black cap which covers her eyes. She had slow speech, low volume, and soft tone. She was seated in a chair with no signs of anxiety. Mood was depressed, but her affect was blunted. There were no crying episodes, though, upon narrate. There were crying episodes when she was narrating her recent breakup. She denied having perceptual disturbances, but during this time, the patient was noted to have poor impulse control. So when I did the diagnostics, I saw that the patient had normal results. Actually, she also brought some laboratory tests initially done at the emergency room. So these are the pertinent findings in this patient. She had depressed mood with suicidal thoughts of 7 days. She has difficulty initiating sleep. So hirap po magsimula ng tulog, probably because of multiple thoughts. And she would wake up in the middle of the night and would have difficulty going back to sleep. So she couldn't maintain her sleep. She then started having alcohol use and she was unable to function very well at work. So my clinical impression at this time was acute insomnia and adjustment disorder with the breast. So for the interest of this lecture, I will be focusing more on acute insomnia. So how do we diagnose a patient with insomnia? According to the the International Classification of Sleep Disorders, the patient should have at least one of the following symptoms. So first is difficulty initiating sleep. So hirap po magsimula ng tulog. Difficulty maintaining sleep. So these are our patients who would be able to fall asleep, but once they are awakened in the middle of the night, it takes a while for them to go back to sleep. And also early morning awakening. So just one of these three symptoms would be required for us to diagnose insomnia. And these symptoms should be accompanied by daytime impairment. So these could be associated with fatigability, headache, decreased mood, anxiety, and etc. So patients are diagnosed with insomnia if they have enough opportunity to sleep. So hindi po kasali tayo yung mga nagpupuyat because maybe we came from the duty and then we only have 4 hours of sleep, then so we feel like we're sleep deprived. So hindi po insomnia yun because we don't have an opportunity for sleep. So these patients, they would have 10 hours to spare, but they couldn't sleep. So patients are diagnosed with insomnia if they've been experiencing this for 3 times per week for at least 3 months. So how does a patient develop insomnia? So according to the Spielman's modified 3P model, it is actually due to the following. First is the predisposing factors, followed by precipitating factors and perpetuating factors. So your predisposing factors are somatic hyperarousal. So this is when, for example, as lectured earlier by Doc Ed, when you experience pain. So before going to sleep, if meron kang headache, masakit yung leeg mo, or earlier lecture, if masakit yung tiyan, or if you are experiencing GERD, then that's a somatic hyperarousal. For cognitive hyperarousal, these are the individuals who would have multiple thoughts when they go to sleep. So particularly patients who would have worries, or those who would somehow summary their day, or even visualize what will happen tomorrow. So these are cognitive hyperarousals. That would also include when we watch very exciting videos or movies before going to sleep. So this is something that will also stimulate the brain. So it's also cognitive hyperarousal. Another predisposing factor is a decrease in homeostatic sleep drive. So this is very particular for shift workers. actually a dual action. So it can be a downer, then it can be a stimulant after 2 hours of intake. So that can also precipitate insomnia. Circadian rhythm disorders, so these are your jet lags, or those with delayed sleep-wake phase disorder. So ito na po yung mga nakakatulog ng 4 a.m. and then they would wake up at 12 noon. So ibig sabihin their body clock is delayed. And lastly, this could be precipitated by a primary sleep disorder. So a second most common sleep disorder po is obstructive sleep apnea or your snoring. So all of these can precipitate your insomnia. And what can cause chronic insomnia, meaning 3 buwan na ho na nahihirapang makutulog, is when we develop behavioral factors or cognitive factors. So yung behavioral factors, ito ang pinaka-common po is when we stay in bed hoping to get more sleep. So patients with insomnia, they feel like dapat makakuha ako ng maraming tulog. I'll just stay in bed para makarami ako, which will actually is a very common behavior that can perpetuate your difficulty sleeping. And cognitive factors could include, yung pinaka-common po is, I need 8 hours of sleep for me to function well the following day, or hindi ako nakatulog kagabi, most likely hindi ako makakatulog mamaya. So these are conditions or situations that can prolong pa your insomnia. So again, a person would develop insomnia if they have predisposing factors. As you can see, are the green bar in this graph.
Recording in progress.
So you just need an onset or a precipitating factor to initiate your insomnia. Then you now develop insomnia. So go beyond the insomnia threshold. Chronic insomnia will develop even if there's no more precipitating factor. Tapos na yung problema natin, but still you couldn't sleep because you now develop your perpetuating factors. So in this case, for our patient CA, what could have developed her insomnia? So the predisposing factors are the following. So first is she's a shift worker. So her shift actually rotates. This is a misalignment in the circadian rhythm. So it now confuses her circadian rhythm. So that is very crucial since medyo hirap na siyang maka-initiate ng sleep even before she had a trigger. Another predisposing factor is her medical condition, which is bronchial asthma. So patients with bronchial asthma are also prone to anxiety, no? And then her environment is identified to be very stressful. So I was not able to mention that this patient is a breadwinner, and her father just passed away a year ago, and she was left with the responsibility of taking care of the family. So these are her predisposing factors. And it was precipitated by a breakup with her partner, her girlfriend. And although the patient only had difficulty sleeping for 7 days, she is now prone to develop chronic insomnia if she continues to utilize alcohol to help her sleep. So now she has a behavioral factor that predisposes to chronic insomnia. So they said that around 1/3 of the population would actually develop insomnia, and 6 to 10% of the population meet the DSM-5 criteria for your insomnia disorder. And people with chronic insomnia report significantly higher rates of several comorbid medical conditions versus those without chronic insomnia. So as I've mentioned, Breathing problems is included in this: chronic pain, hypertension, GI problems, heart disease, urinary problems, and neurologic disorders. And insomnia was prevalent in adults with psychiatric disorders such as your major depressive disorder, anxiety disorder, schizophrenia, and bipolar affective disorder. DSM emphasizes the need to diagnose insomnia disorder whether it occurs as an independent or is a comorbid of another psychiatric or medical condition. So the goals for the treatment or management of insomnia are the following. First is we need to reduce your sleep and waking symptoms, and we have to improve our daytime functioning, and most especially to reduce distress. So the general approach to treatment makes sure that all patients with insomnia should receive therapy for any medical condition, psychiatric illness, substance abuse, or sleep disorder that may be precipitating or exacerbating the insomnia. And treatment should be individualized. Cognitive behavioral therapy for insomnia, CBTI, rather than your medication, should be initial therapy, but can be combined with your medication initially. So what are the components of your CBTI or your cognitive behavioral therapy for insomnia? So we start with sleep restriction. So sleep restriction, ito po yung we tell our patients that they can only go to bed within a sleep window. So what we're trying to do is we want to increase their homeostatic pressure for sleep. Kumbaga, pinupuyat natin sila para mas sure po tayo na makakatulog sila. So how do we do this? So for example, in our patient, CA, she would sleep right now. She said she would have around 4 to 6 hours of sleep. So maximum would be 6 hours of sleep. She intends to be awake at around 11 a.m. So we count backwards 6 hours, and then we identify the bedtime as 3 a.m. So we tell our patient na, okay po, you just go to bed at around 3 or 4 a.m. and then you make sure that you get up at around 11 a.m. So you cannot go to bed earlier than that, or you cannot extend your sleep later than your 11 a.m. Another form of a psychologic treatment is your stimulus control therapy. This is the easiest advice that you can give your patient. You just tell your patient that the bed is only for sleeping, period. For those with partners, it could be divided into 50% sleeping, 50% sex. So you tell your patient you want your brain to know that whenever you look at the bed, ang magla-light up sa brain nila is sleep. So that is stimulus control. If they do a lot of things in bed, which is what I'm sure everyone is guilty, where when we watch TV in bed, when we read a book in bed, when we use our phone in the bed, the brain would be confused. He would ask you, what are you trying to do? Are you trying to sleep or are you trying to do other things? So since when a patient experiences insomnia, we want to contain the stimulus of your sleep. So we just tell the patient that you can only go to bed when you're sleeping. Sleep hygiene techniques, there are a lot. I want to emphasize that this is individualized. What I mean about individualized is that there would be rules stated online that might not work for your patient. A very common one is watching television. So a lot of us would be watching television while we sleep. Some would fall asleep, but some cannot fall asleep with the TV on. So for those patients who are able to fall asleep with their television on, they might be using the television as a white noise. So it could be a white noise or a relaxing sound. So if that is the case, then you can allow them to turn on the TV while they're trying to initiate sleep. Fourth are your relaxation strategy. So this can be your breathing exercises, your progressive muscle relaxation, your yoga prior to sleeping. And lastly is your cognitive therapy. This is when we challenge our patients regarding their wrong beliefs about sleep. So I've mentioned earlier that kailangan ko ng 8 hours, doktora, para makapag-function ako well the following day. No? So, medyo i-challenge yung pasyente. You ask them, was there a time that you needed to be awake early and you had only around 4 hours of sleep, but you were still able to function well? So, ang pinaka-common dyan, yung pag meron po tayong flights na hinahabol, so kailangan maaga tayo sa airport. So, minsan maiksi lang tulog natin, pero nakasakay naman tayo ng eroplano. We were able to go through all the toxicities in the airport. So that's a very good example to challenge the idea that you actually need 8 hours of sleep for you to function well. So when you see a patient in the clinic complaining of difficulty sleeping, try to use at least one of these techniques. You don't need to gamitin to sabay-sabay. Actually, the most effective one would be a combination of the four or of the five techniques, but sleep hygiene would be okay. No, but sleep hygiene alone cannot be that successful. So you have to combine it if either with sleep restriction, sleep hygiene, with stimulus control, and etc. So for tonight, we're gonna talk about pharmacologic treatment. But before I go into that, I would like to explain how do we fall asleep at night chemically. No? So yung brain naman natin. So our brain actually has wake-promoting centers. So these are the neurotransmitters that are stimulated when we wake up. So these are your orexin, your serotonin, your norepinephrine, your histamine. And when we sleep, our sleep promoting centers naman would turn off or dampen this arousal neurotransmitter. So the most common would be your GABA. So our brain is like a switch, or our sleep is like a switch. So in the Okay, so here in the awake, or ORX is your orexin, will actually stimulate your serotonin, your histamine, and norepinephrine, which would then inhibit your GABA. So when that happens, it's like a switch. It turns on and then you're awake. When you're asleep naman, when you're asleep, your GABA then inhibits your orexin. So when your orexin is inhibited, it actually stimulates your serotonin and your norepinephrine, but then your GABA still inhibits these neurotransmitters. So it's like a switch off. Then you fall asleep. So these are the pharmacologic treatment that are approved by the American Society of Sleep Medicine for your insomnia. So for the first type of insomnia, which is the difficulty initiating sleep or the sleep onset insomnia, all right, look at the medications here. So if you will notice, there's only one available in the country, and that is Zolpidem. And for our sleep maintenance insomnia, so these are the individuals who would wake up in the middle of the night and would have difficulty going back to sleep. Again, there's just two medications that are actually available in the country. You can see again your Zolpidem and Suvorexant is actually a similar drug with your Lemborexant. And we would commonly give our patient the following medications: your diphenhydramine, your melatonin, your valerian root, and other supplements. But it is not recommended in the treatment of your sleep onset and your sleep maintenance insomnia, according to the American Society of Sleep Medicine. So for tonight, I will talk about your our Lemborexant. So orexin, as I've mentioned earlier, is a neuropeptides system role in the wakefulness, right? So its mechanism of action is thought to regulate your wakefulness in the brain. The mechanism of action of this lemborexant or Dayvigo in the treatment of insomnia is presumed to be through the antagonism of your orexin receptors. So there is a blockage of the wake promoting neuropeptides orexin A and orexin B to receptors OX1R and OX2R, which thought to suppress your wake drive. So again, if you can visualize your sleep switch, your lemborexant actually inhibits your orexin, hence stimulating sleep. So they did two very big trials. These are randomized controlled trials, phase 3. First is the Sunrise 1, followed by your Sunrise 2. So for Sunrise 1, this is a 1-month treatment period, comparing your lemborexant 5 milligrams and 10 milligrams with a placebo and IR active comparator. So they wanted to see if your medication is comparable in initiating your sleep or your sleep latency onset or latency to persistent sleep versus your placebo using a polysomnography. So nag-sleep study po sila. While the Sunrise 2 is a 6-month placebo-controlled trial comparing your lemborexant with placebo. They would like to know if patients are sleeping faster, but this time they're using sleep diaries or your patient diaries. So the difference is for Sunrise 1, this is an objective finding, while your Sunrise 2 is a subjective feeling. The subjects in these two trials are relatively older population. So for Sunrise 1, average was around 64 years old. But in Sunrise 2, they were able to include more than 18 years old subjects, but the average is around 55 years old. They use your DSM-5 criteria for identifying your patient. And you can see that your insomnia severity index are actually higher in Sunrise 2 than in Sunrise 1. But both are actually severe insomnia. So the exclusion criteria, so they did not include patients with restless leg syndrome, periodically movement disorder. So ito yung may mga kuya-kuy sa gabi or yung mga hindi mapakali yung paa sa gabi. Narcolepsy also is not included. So these are the patients with excessive daytime sleepiness, antok-antok in the middle of the night with cataplexy, yung parang bigla kong nawawala ng body tone when they experience extreme emotion. So this could be excessive happiness or excessive sadness. They also did not include your circadian rhythm disorders, so those with the late sleep wake phase, as mentioned earlier, and patients with sleep-related breathing disorder, those who are may obstructive sleep apnea or central sleep apnea. They also did not include complex sleep-related behavior, so our parasomnia patients, those with sleepwalking, dream reenactment as well. And for depression or anxiety, moderate to severe patients were not included. But be mindful that some of the patients actually included in the study, those with mild presentation of your depression. They also include patients with migraines, which is actually our patient, and those who are menopaused and with generalized anxiety disorder, hypertension, and diabetes. So the results are the following. So for your Sunrise 1, they saw that versus your placebo patients on lemborexant 5 milligrams were actually sleeping faster. So when they're on placebo, it takes them around 20 minutes, but when they're on the medications or lemborexant, it only took around 15.5 minutes. And for those on Sunrise 2, so this is the subjective feeling of the patient, the lemborexant is still better than your
Bulok na
placebo
yan.
with sleep onset
Alam na yan,
latency
galawan na yan. Bali na
of 20 minutes. And they also checked if when the patient wakes up in the middle of the night, were they able to go back to sleep? So yung sa Sunrise one po, according to the sleep study, there was a very big decrease in their in the minutes of before they can go back to sleep. And so as you can see, baseline was 113 0.4 minutes. So, ang tagal nila bago makabalik sa tulog, almost 2 hours na. But when they're on Davigo, nabawasan po yun ng 45 minutes. And this is the same with your Sunrise too. So it is actually the same with your objective finding during the sleep study and also the subjective feelings of the patient. So these are the noted side effects of our patient. Of course, this is a sedating drug, so patients would experience somnolence on an increasing dosage. So mas inantok ho o mas na-sedated yung 10 milligrams. Some patients complained of headache and some patients complained of nightmares or abnormal dreams. To tell you honestly, this is the most significant reason for discontinuation, and it actually came out of the study as well. So some patients would discontinue because the dreams are very vivid. So I have a patient, they could not decipher if it really happened or it was just part of the dream. So they would check their bed part. Uy, ginawa ko ba ito? Ganyan. So that actually contributed to the discontinuation. So just be mindful and exercise caution when using higher dosage, higher than 5 milligram for patients more than 65 years old. Just be mindful that they might get sedated and be at risk for fall. So how about dependence, withdrawal, or rebound with this type of treatment? Studies suggested that your chronic use for Davigo did not produce physical dependence. But of course, for patients with tendency for addiction, you have to be cautious because dependence can be both physical and psychological dependence. So these patients might develop psychological dependence on the medication. It is also said that Davigo is not associated with rebound insomnia when you discontinue your medication. Meaning, kung hindi ho kayo, if your sleep is fixed already and you stop taking tonight, tomorrow you will be able to fall asleep, because for your Z drugs and for your benzodiazepines, there would be for sure a difficulty going back to sleep because of the withdrawal from the medication. And I would like to emphasize that this is not an S2 drug, so you don't need your S2 license for you to prescribe this medication. So let's go back to our case, CA. We diagnosed her of adjustment disorder with depressed mood. Adjustment lang po kasi hindi pa po siya umabot ng 2 weeks when I saw her. And this is how I manage her case. So for her suicidal ideations, of course, I would advise admission during this time. But still the family and the patient refused and did not give consent. So I just gave them suicide precautions, no? Make sure that sharps are kept away from the patient, make sure that the patient has 24/7 watcher, yung mga ganun po. And then I also created a safety plan, meaning once the patient would be able to identify what are her triggers that make her think of hurting herself, and what can she do when she has these triggers, and who can she call, no? Sino yung pwede tawagan kapag hindi na niya makontrol yung kanyang triggers. So this is what we call the safety plan. So for the depressed mood, I started her on an antidepressant. I wanted to give her something stimulating, a non-sedating antidepressant, since our patient is working. So for our patients who needs to be awake during the day and needs to be focused, it is ideal that we give them something that is non-sedating antidepressant. So for insomnia, I instructed sleep hygiene. And then I made a request. So I asked her, what shift are you most comfortable staying for now? Because as I mentioned earlier, her shift will move. So nagro-rotate ho talaga siya. So one thing that we advise is just to stick to one shift. So for me to be able to fix her sleep, I need to identify what shift is she most comfortable. And I just wrote a recommendation. I also started her on sleep restriction. So I gave her a sleep window, a schedule, and then I started her on lemborexant. So she may take this when she's in bed, when about to sleep, so she can lie in bed and then take this medication. And for my future plans, I would like to see her again after a week just to monitor her depressive symptoms and suicidal thoughts, and also monitor if she still needs the medication for sleep. So on follow-up, the patient had improved mood but still with depressive episodes. She had intrusive thoughts mostly about the past relationships. She was sleeping well and only took lemborexant for 7 days. She was able to go back to work after 7 days. So in summary, sleep is actually the most important symptom in all psychiatric conditions. So pag tinignan niyo ho yung DSM-5, lahat ho yun, may difficulty sleeping. Manage it separately from the psychiatric condition to improve the outcome. CBTI is the first line of treatment, but combining it with the right medication during acute treatment is recommended. Thank you very much for listening to my lecture, and hopefully we sleep well tonight. Thank you.
Thank you, Dr. Kim. So thank you. It's very interesting to know. For all that we are talking about a medication na we could use pala even without our S2. Kasi yun yung nagiging
Oo.
problem natin, Doc Kim, no? Ako, I gave up
Mm.
my S2 a long time ago dahil lagi ako nilalapitan ng mga ano. Di ba that's the problem eh. So, well, anyway, so meron masyado tayong maraming liabilities whenever we fit to people who we know would really abuse this medication. So it's a good thing with lemborexant, it's an S2 pala. So we could just
Yes.
prescribe them and they can buy it on. Anyway, so with sleep, Dr. PM, actually this is one of also the most common problems that we encounter in our workplaces. Kasi syempre, workplace yan, lahat naman is, hindi, most of the time, meron talagang shifting. That's the reason why also our first question in the chat box here is about your advice on the sequence of shifting work. So, sabi ni Doc Jan, is what is the advisable sequence for shifting work? From morning to 2 p.m., then to morning again, every 2 weeks ba or every 4 weeks? Or every 2 months to avoid sleeping difficulties. Meron kasi mga contradicting suggestions from all over. So, in your practice, Doc Pin, so what can you say about this
Okay.
one?
So once the patient comes in because of difficulty adjusting to the shift, we tell them to quit. It's not for you. Okay. So the first thing is to screen a patient. Is the patient well during shifting? So before we even think of the right shift, we look at the right employee. So yung mga sanay ho magpuyat, bagay po sila sa shifting. Kasi kaya ho nila magpuyat. And they can sleep during the day. But for our morning person, hindi po yan kaya. So they cannot force themselves to sleep during the day. So out na ho sila. Medyo mas mahihirapan sila sa shifting. The best schedule can only be paired with the best with the right body clock of your employee. So minsan yung employee mismo nakakaramdam na ito yung okay sa akin na shift. So ang advice talaga namin is just to stick to one shift. Isa lang, sorry. Hindi talaga kami hindi namin ina-advise na nagro-rotate siya. Pero 'di ba, parang hindi naman yun totoo. Kasi kahit sa nurses natin, nagro-rotate naman talaga yung shift. So, what we do at the sleep laboratory, because we also have technicians that rotates, ano po, 3 weeks. So, 3 weeks po sila night, and then ganun po ulit during the day. So, umiikot lang ko sila every 3 weeks. That's the ideal. But then again, there are group of patients talaga that who could adjust well in a shifting work.
Thank you, Dr. Kim. Yun nga, ideally, ganun sana. However, di ba, kahit sa healthcare naman talaga, nag-shift naman talaga. And talagang majority of the industries talaga, we do shift work. Kaya, yes, talagang, I think we should stick dun sa, dun sa practice nyo na 3 weeks. Kasi, for some of us, a majority actually 2 weeks talaga. 2 weeks, minsan 4 weeks. Legal tayo, 3 weeks. So, thank you for that. So we have another question here. So let's talk about Lemborexant naman, Doctora. When is the best time for us to be able to start with the medication for these types of individuals? Siyempre, initially muna, you interview the patient, anong problema, gaano katagal ka na bang hindi masyado makatulog, no? Nahihirapan ka. So, kailan yung ideal na, sige, start na tayo na ganito? Or should we start with, diretso na ba tayo? First line na pa kaagad natin ito? O we could start with kahit melatonin lang muna?
Alright. So, your medication, any medications for sleep po, are only advised during the acute phase. Doon lang siya effective. You notice when your patient po, matagal na silang umiinom, sasabihin nila sa'yo na wala na siya ng bisa. So, wala ng bisa yung gamot. Kailangan ko na ng iba. Kaya, kami ho, once the patient complains of difficulty sleeping, and then you see, like my case, nasa distress na talaga siya, hindi na niya kaya, and then she's taking alcohol na, nagsiself-medicate. We start the medication when you get these types of patient. Melatonin po is not recommended, but for shift workers, pwede mo siya supplement. But in cases of my comorbid na depression or anxiety, it might not work at all. So, ang important na ho, when you give this medication, you have to monitor them. Hopefully, they'll be okay in 7 days. So, for the success to be higher po, na 7 days mo lang ibibigay yung gamot, don't forget your sleep restrictions, sleep hygiene, yung mga ganun po. And then manage the comorbid. So, kunyari, may pain sa neck, o bigyan ho natin ng pain reliever. Or yung sa akin ho, it's more of the anxiety and depression. We also give them the antidepressant. So, for me, the ones na nakita mo na siya, and then nakita mo hirap na talaga siya, you give the medication to your patient.
Thank you, Dr. P. May follow-up tayo dito. Sabi ng isa nating participant, how many minutes or hours before the target sleep onset time should Lemborexant be taken?
So, you identify, tama po, the target sleep onset. So, malalaman mo yun kung what time pa usually natutulog yung patient mo. Ideally, nasa higaan na ho. So, this type of medication, medyo mabilis siya. So, nasa bed na, and then you take it and you don't do anything na po after that.
Okay, so the next question, actually, we have 3 participants na meron silang question, pero they're all the same. The question is, for how long can we give Lemborexant? I'm sure you mentioned kanina sa 7 days time. But can it be a maintenance? Ano yung pinakamatagal from your experience, Doktora, na nabigay mo siya ng dire-diretso?
Oo, since bago pa ho yung gamot. So, parang, as far as I can remember, parang meron ho akong patient on it for 3 months. But what I noticed is he does not take it every night, which is actually good. No, kasi unlike other your benzos kanina, clonazepam, your zolpidem, they have a tendency to take it every night. So yung sa lemborexant po, parang kaya nila na auto night because siguro puyat ako kagabi, so easier to fall asleep tonight. Parang they can skip. As you can see in the lecture in the study I presented earlier, 6 months. So they gave lemborexant to patients for 6 months. So you can take it as long as 6 months.
The study, may hanggang 6 months lang sila. Pero doktora, ang initial management natin, ang regimen natin is kinakailangan yung 7 days na yun. Dire-diretso, araw-araw muna silang, gabi-gabi muna silang inom nun. And thereafter, saka sila po pwedeng mag-skip in between, tama? Or po
Okay.
pwedeng,
So, ang pinaka-fear ng patients na may hindi makatulog is kapag hindi na sila pwedeng uminom ng gamot. So, ang binibigay ko sila, you can take it 1 week, bahala ka kung gusto mo siya take every night. It's up to you. So then they are reassured na, okay, I can take it. So minsan, parang nakakalimutan din nila. Minsan nakakatulog na sila without it because there's no pressure sa patient. But yes, 7 days tuloy-tuloy, and when you plan to taper it po, you can give alternating days the following week, and then you see them again if there is a need. They will inform you naman if there's still distress, hirap pa rin makatulog kapag nagsiskip po sila ng lemborexant.
Thank you. Doctor, how about the contraindication? Do we have an absolute contraindication for lemborexant also?
Yes po, narcolepsy. So patients with narcolepsy, you cannot take this. Kasi yung patients po na may narcolepsy, wala na po silang orexin. So they have deficient orexin in the brain. Kaya sila nakakatulog during the day. So those with hypersomnia, antok na antok ho during the day, try to avoid giving this medication. When you have liver diseases, you divide po 50% the dosage of your lemborexant.
How about for the drug interaction, Victoria?
Oo, always naman bawal po talaga with alcohol, no? We cannot give or we cannot combine this with alcohol or other benzodiazepines pa po. So parang magpapatong na ho kasi yung sedating effect ng medications.
And so we have last question here. Okay, so this is medyo timing right now, di ba? We are anniversary yata ng Marawi. So the question is actually about the yung post-traumatic stress, no? The question for those with post-traumatic syndrome and still with insomnia, what will you suggest? We had medical missions in Marawi, and most of them complaints of difficulty sleeping. So would taking this medication help them also?
As I mentioned earlier, one of the effects are nightmares. So, di ba yung PTSD patients natin, they have very bad nightmares of the event. So, I do not suggest that you give this. What works well are antipsychotics. So your olanzapine might work well. It's a sedating antipsychotic. Pwede po yun. A very low dose like 2.5 or 5 milligram. You can also give your risperidone for PTSD patients. But I do not recommend this one.
May tanong pa. Has it been approved as halal?
Yeah, actually, I never asked this. But this is from, I'm not sure. I cannot answer. Sorry, sir. But that's a very good question, especially for those with Muslim patients. Yeah, maybe I'll get there. Maybe as I can answer that question.
And so with that, ang dami questions, Sukora. Pasensya na.
Oo
No?
nga po. Pagtulog talaga.
Oo, pero talaga this is a very interesting lecture, and this is not something na naririnig namin sa mga webinars, no? So it's we are really privileged to have you all here as our speakers for tonight. And with that, thank you once again. It was a very comprehensive lecture. We've learned a lot about all the lectures that you gave us, and of course, we will surely be using all of this additional knowledge in our clinics pagbalik namin. Ano pa na kaya? Friday pa lang. Wala na akong pasok bukas. Ganun pa pala. Okay, and with that, thank you again, Doc April, Doc PM. No, sabi kasi nila, ang nickname mo daw ay Dr. PM. Okay, so thank you, Doctora. And hope we can see you also again soon. No, so we can invite you again soon. Thank you. And I guess at this point, I would like to turn over the floor to our host. Once again, I would like to take this opportunity to thank everyone for attending, and